ventilation using pressure limited ventilation. Introduction. That non-invasive ventilation described as BiPAP, and the BiPAP is actually the trade name, as the name suggests, provides differing airway pressure depending on inspiration and expiration, and the inspiratory positive airway pressure, that is IPAP, is higher than the expiratory positive airway pressure, that is EPAP, and therefore ventilation is provided mainly by IPAP. And here that before intubation, given its ability to provide 100% oxygen and positive end airway pressure and ventilatory support. And here is the only way to improve upon the oxygen by administration of the positive airway pressure. Apneic ventilation using a BiPAP machine with a spontaneous time mode. So here we can see the time set in the IPAP machine, that is BiPAP machine, that is IPAP rate is 12 and the time, that is 1 is to rise, and EPAP 4, that will be dependent upon the spontaneous respiration or the spontaneous breath that the patient will be taking. And here you can see the diagram, that is dependent upon the spontaneous breath the patient is taking, the BiPAP machine will be support. And in acute setting, and the non-invasive ventilation is used in type 2 respiratory failure, for example in COPD exacerbation with the respiratory acidosis, mainly that the pH is, patient's pH is less than 7.35. And the transitioning from spontaneous breathing to machine triggered ventilation, and here the transition into ventilator supported breathing may be seamless and the patient breathes spontaneously. So we used to set the rate of 5 to 10 minutes below the patient's respiratory rate. How we have to keep the airway open, and at the time of performing the apneic oxygenation, and the airway is commonly occluded. So here what will happen when the patient is taking the spontaneous respiration, the tongue may fall backward after paralysis. So the main one advantage of apneic ventilation, because it will mainly monitor whether the airway is open. So here you can see the machine will display the tidal volume, the actual tidal volume received by the patient. Coming to the machine settings to optimize oxygenation, and here is the physiology of recruitment, understanding, and in case if you are giving a positive pressure to recruit the lung, we will be thinking about mainly for COPD patient, and we will be giving the feed support. We will be giving the feed support, and however PEEP is only a part of the story. So mainly for the patient with respiratory failure, type 2 respiratory failure like COPD, we will be giving 5, that is PEEP support will be used to give 5 PEEP support. And here you can see the transpulmonary pressure on BiPAP, that is commonly 15 cm by 5 cm for active inspiration and expiration. So for active inspiration, that is 15 minus 15. So that is 15 plus 15, overall the transpulmonary pressure will be 30 cm. But in the case of escalation, the transpulmonary pressure, whatever the patient is breathing, that is 5 minus whatever we are giving, 8. So it's minus 3. And if you are seeing this scenario, lung recruitment only occurs during inspiration. So the transpulmonary pressure, that is at the time of inspiration, that whenever the lung recruitment occurs, that is we are giving plus 30 cm. But at the time of escalation, the transpulmonary pressure is decreasing, that is minus 3 cm. So this de-recruit the lungs, that is relaxation. So that's the primary factors opening up her lungs. Actually the peak pressure of BiPAP machine is plus 15 cm, and the negative pressure produced, that is 15 minus 15 cm. And the transitioning from spontaneous breathing to machine triggered ventilation, and here the transition into ventilator supported breathing may be seamless and the patient breathes spontaneously. So we used to set the rate of 5 to 10 minutes below the patient's respiratory rate. and how to set the BiPAP machine during apnea to optimize transpulmonary pressure. So here transpulmonary pressure equal to positive end expiratory pressure, that is plus peak pressure minus peak percentage of time inhaling. And in coming to the driving pressure, peak pressure minus PEEP, and the transpulmonary pressure equal to PEEP, that is positive and expiratory pressure plus the driving pressure, that is the total percentage of time inhaled. Coming to the machine settings to optimize oxygenation, and here is the physiology of recruitment, understanding, and in case if you are giving a positive pressure to recruit the lung, we will be thinking about mainly passive meditation, and we will be giving the PEEP support. We will be giving the PEEP support, and however, PEEP is only a part of the story. So mainly for the patient with respiratory failure, type 2 respiratory failure like COPD, we will be giving 5, that is PEEP support will be used to give 5 PEEP support. And here you can see the transpulmonary pressure on BiPAP, that is commonly 15 centimeter by 5 centimeter for active inspiration and expiration. So for active inspiration, that is 15 minus 15. So that is 15 plus 15. Overall, the transpulmonary pressure will be 30 centimeter. But in the case of exhalation, the transpulmonary pressure, whatever the patient is breathing, that is 5 minus whatever we are giving, 8. So it's minus 3. Machine settings to optimize ventilation. So less commonly than hypoxemia, here in case if the patient is severe metabolic acidosis, is pH will be reduced and bicarbonate will be less than 22. And here what will happen, the compensated respiratory alkalosis. So respiratory alkalosis, that the patient with hyperventilation, if you are keeping the patient for connected the patient on mechanical ventilator for a long time, so what will happen here, the FiO2 level will be increased, and the carbon dioxide level will be decreased. So the carbon dioxide level will be less than 35, and the FiO2 level will be above 100. So here mainly what a patient it will be occur means the patient with the diabetic ketoacidosis or salicylate intoxication. So these patients are a risk of acidosis in peri-intubation period, because we are taking away their compensatory respiratory alkalosis and potentially replacing with the respiratory acidosis. And such type of intubating this type of patients, better we should avoid intubating this type of patient, because sometimes what will happen if the patient is going for a unconscious or in a need of ventilation with a severe apnea, and we are in a risk to do the ventilation. But such a situation, all efforts must be made to maintain better. We have to make sure we are maintaining the PO, the partial pressure of carbon dioxide level between 35 to 45. So as low as possible at the peri-intubation period. And how to set the BiPAP machine during apnea to optimize transpulmonary pressure. So here transpulmonary pressure equal to positive end expiratory pressure, that is plus peak pressure minus peak percentage of time inhaling. And in coming to the driving pressure, peak pressure minus PEEP, and the transpulmonary pressure equal to PEEP, that is positive and expiratory pressure plus the driving pressure, that is the total percentage of time inhaling. Introduction. That non-invasive ventilation described as BiPAP, and the BiPAP is actually the trade name, as the name suggests, provides differing airway pressure depending on inspiration and expiration. And the inspiratory positive airway pressure, that is IPAP, is higher than the expiratory positive airway pressure, that is EPAP, and therefore ventilation is. And sometimes what will happen, the pressure limited ventilation, the peak pressure is set by the practitioner. and the volume will be vary depending on the lung compliance. So some generally be achieved by either volume set or a pressure set ventilation. And for purpose of apneic ventilation, pressure limited ventilation has some unique advantage. So pressure limited ventilation, most people opt for the pressure limited ventilation because it is one of the safe, it gives one safe inspiratory pressure. So the pressure limited ventilation, the inspiratory pressure, if you are keeping a safe inspiratory pressure, better you have to keep the inspiratory pressure at a level of 15 centimeter because it will give the safe pressure. And alternatively, what will happen, we may set the volume limited ventilation, then what will happen, if you are keeping alternatively again volume limited ventilation, there may be a chance of high pressure will be occurring. And in volume limited ventilation requires close monitoring with adjustment of tidal volume. So the tidal volume we have to monitor, and we should adjust, either titrate or increase depend upon the patient pressure. And it is to that why we are doing adjustment, because sometimes it will be causing a dangerous rise in pressure that will be go beyond the level, so it will be causing complication for the patient. So here such type of patient, beyond the pressure variation is there, better we have to check, and ongoing observation should be done. Coming to the pressure limited ventilation maximizes the efficiency of inspiration. So when compared with the volume limited ventilation, the pressure limited ventilation will maximize the tidal volume, that is peak pressure of 15 centimeters. So here the airway pressure will only reach the peak pressure at a very last moment. Introduction. That non-invasive ventilation described as BiPAP, and the BiPAP is actually the trade name, as the name suggests, provides differing airway pressure depending on inspiration and expiration. And the inspiratory positive airway pressure, that is IPAP, is higher than the expiratory positive airway pressure, that is EPAP, and therefore ventilation is provided mainly by IPAP. And here that before intubation given, when should apneic ventilation be considered? So when you are supposed to consider the apneic ventilation. So it's one of the important tool, and the patient may be benefit include those, mainly the patient those who are with the severe hypoxemia, severe metabolic acidosis, so that it's in a dangerous zone. The bicarbonate level is very less than 15, that is a very dangerous level, or there is in a case of severe metabolic acidosis or any morbid obesity, we have to place the patient, we have to consider the apneic ventilation. And if you are seeing this scenario, lung recruitment only occurs during inspiration. So the transpulmonary pressure, that is at the time of inspiration, that whenever the lung recruitment occurs, that is we are giving plus 30 centimeter. But at the time of exhalation, the transpulmonary pressure is decreasing, that is minus 3 centimeters. So this de-recruit the lungs, that is relaxation. So that's the primary factors opening up the lungs, actually the peak pressure of BiPAP. And in case a sport mask ventilation technique is critical to maintain open airway in case after paralysis, and if you are using pressure limited ventilation during apnea, it will be avoid high inspiratory pressure. So better opt for pressure limited ventilation. And in case the patients with the severe hypoxemia may be benefited with the PEEP support, we will be start from 5, and the patients at risk from hypercapnia may benefit more from higher driving pressure.